Thank you very much. I'm Sarah Hewlett. I'm Professor of Nursing at UWE and I'm a consultant nurse at UH Bristol. I'm representing Bristol Bones and Joints today. So, like all the HITs, we're trying to integrate our clinical services, our research, our education and training across the two big rheumatology departments in Bristol. And to do that, we have three main disease conditions that we have a theme for each: osteoarthritis, inflammatory arthritis and osteoporosis. And because these are long-term conditions, we have another underpinning theme, which is self-management support. We have a couple of cross-cutting themes, which are how we collaborate with patients in our HIT, our research and our clinical services, and the information that we're going to provide. So it's a partnership between UWE and University of Bristol, between the two main healthcare trusts that have rheumatology departments, and of course the patients are at the centre of it. We have links into primary care, with Terry here, and also we've been making links with our clinical commissioners for long-term conditions from Bristol City Council. So what are the overarching aims? For the three condition themes, osteoarthritis, our aim is to devise primary care pathways for osteoarthritis and also surgical pathways. For inflammatory arthritis, we want to develop a stepped care, so from the intensive treatment of early diagnosis and getting drugs sorted out, through to self-management and then follow-up, which is lifelong, and into a direct access service whereby patients will call us when they need us in secondary care. We will see them within a few days. If they don't call us for 2 years, then they will have an hour-long review with a specialist nurse for inflammatory arthritis. For osteoporosis theme, we're trying to develop primary and secondary fracture prevention pathways. For our self-management support, we want our patients to have access to evidence-based support for self-management across the trusts in particular. For collaboration with patients, they are helping us prioritise what's going on in the HIT, and for the information theme, we're developing a website which will be a single point of access for both patients and professionals to understand musculoskeletal resources available in our area. So what have we done? For osteoarthritis, we now have the National Bone and Joint Registry here and we've been doing the analysis on that. There's evidence that cemented hip replacements are more cost effective than uncemented ones, and so Ashley Brom's got agreement from surgeons all across the two trusts to use cemented hip replacements where possible. So the number has gone up from 40 to 92%, with a saving of about £170,000 a year for the trusts. And we're hoping that the Academic Health Science Network will help roll that out beyond the Bristol boundaries. In terms of the inflammatory arthritis programme, we've created standardised drug monitoring guidelines for GPs. So our GPs monitor these noxious drugs every month, but if you have a GP with a patient in two different trusts, they've been receiving different information about the same drug. So we've looked at the evidence and we've come up with a single drug sheet for every single drug, which we'll update every 2 years. We've now got a rheumatoid arthritis patient pathway from initial diagnosis through the first year, with very intensive treatment and hospital outpatient appointments with all members of the team for the first few months in particular. This is an evidence-based primary care inflammatory care pathway, and it's been given a Best Practice Award by the British Society of Rheumatology. And North Bristol Trust has now utilised the information that we've done and done their own evidence-based research, and they're setting up a similar but slightly different, equally evidence-based pathway. For osteoporosis and fragility fractures, they've started setting up regular pan-Bristol meetings. They've, for example, just had a meeting with a dentist on osteoporosis of the jaw, which is quite unusual. They've developed patient-based quality indicators for their DEXA service, and they're now trying to work on incorporating vertebral fractures into the fracture liaison service. For the self-management theme, we've had a meeting across the trusts for the first time for those people who are involved in delivering musculoskeletal care self-management programmes, and we've made an agreement that where possible we will be using evidence-based interventions and that we will not be using didactic information such as I'm going to now, because we know that education alone does not change behaviour. So you need an underpinning theory of cognitive behavioural and social cognition to change behaviour. We have a big programme of research into fatigue self-management and inflammatory arthritis with a 7-centre trial that we're running, and that's a cognitive behavioural intervention. We have a programme of work looking at the needs of men for support in inflammatory arthritis because they don't access it and it looks like they don't like our female gendered services. And we've done a scoping exercise on the national guidelines for providing psychological support to patients with inflammatory arthritis versus what's happening in practice, which is basically nothing. And we have an OA self-management theme programme, which I will explain a little bit more in a moment. For the patient collaboration, we have worked very hard with our patients who are on our executive and also wider patient consultation. So we held 2 meetings. The first meeting in 2013, about 50 patients came for the day, and we gave them lots of tasks to do. They recommended that we had PPI in every pathway that's developed, so as it's developed with patient input. We tried to make sure we include the hard-to-reach groups, and that those pathways should be evaluated. In terms of training, what they wanted was more collaborative shared decision-making with the rheumatology teams in hospitals, and they implied that we needed training for staff, and they'd be very happy to help train. And so we do now have patient involvement in all our pathways, and we've started doing some research into what it means to train a clinician to do more shared decision making. Our last meeting, which was last year, again about 50-60 patients, was really concentrating more on the self-management. And again, patients saying you need this holistic care, and you need to include psychological well-being, not just looking at our painful swollen joints, look at the whole of it. Again, they talked about training staff and collaborative care, but they also then mentioned actually patients need to be activated to self-manage and engage as well. So we now have a grant application underway for a 5-year programme for one of our senior research fellows, a psychologist, to develop those training and evaluate it for both patients and clinicians. And we have a fellowship on the needs of men with RA. Osteoporosis, what came out of this meeting is that patients want their DEXA results, please. We don't just want them sent to the GP. And so again, another grant application is going in for a programme of work around osteoporosis, and patients do now indeed receive their DEXA 7s. In the informatics scene, we now have a draft website which is going to be piloted in the next couple of weeks, which will be that primary source of access, and we involve 2 of our specialist trainees, our registrars who developed this. So what are we going to do next? For the osteoarthritis pathway, we are going to try and roll out that cemented total hip replacement as a normal practice beyond Bristol, and in a randomised controlled trial looking at the management of surgical infection and joint replacements. The inflammatory arthritis scheme, we want to roll out this direct access service where patients are driving access to the secondary care services into other inflammatory groups such as psoriatic arthritis. In the osteoporosis theme, we're doing research into medication adherence. For the self-management support theme, we're just in the middle of a scoping exercise, so we're trying to understand exactly what self-management support is offered across the 2 trusts, not only in terms of group programmes, for example, run by physiotherapists or pain management teams, but also one-to-one interventions by people like myself on fatigue or psychological support. And then our eventual aim is that any patient from any trust in the rheumatology services should be able to access those programmes, no matter where they're delivered. So if I have a patient at UH Bristol, can't come to my Tuesday clinic, but there's an equivalent clinic in North Bristol, why shouldn't they go there to get their self-management support? Let's cut the red tape. We have a PhD student who will be looking at patient activation into self-management and engagement. And I say we have our 5-year grant under review for providing psychological support and clinician training on that. We'll be piloting our website, and we'll be piloting it on the 22nd of June, which is when we have our 3rd patient involvement meeting. Again, we're hoping for another 50 or 60 participants. I know we've got about 40 signed up at the moment. And they'll be concentrating on the website and again on that self-management programme story we take on. So just as one example then, it's quite hard to implement programmes that are not, for example, surgical or drugs. Once you get into non-pharmacological, multidisciplinary team interventions, even if they're effective, it's quite difficult to get people to change their behaviour, and I mean the clinicians. So this is Nikki Walsh, who's an associate professor in physiotherapy at UWE. She ran the 6-week self-management intervention, exercise intervention, delivered by physios in primary care. It was a big randomised controlled trial, producing big cost savings compared to general physiotherapy for OA knee and compared to standard GP care. It's been rolled out and implemented now, the ESCAPE programme, in 10 boroughs in London, and that's with the support of the Academic Health Service. However, it has been 10 to 15 years since the start of the original trial in 2001 to starting to get implementation in 2015, despite having nice and quick approval and a website where physiotherapists can just download the manual and start teaching. And so we had some quite useful help from the last group before lunch as to where we might go with this and why it is so difficult to implement self-management and non-pharmacological interventions across the board. So if you have any advice, we'd be delighted. And we're the 3 co-directors, and these are the contacts for any of the themes. We'd be very happy to hear from you.
Thank you.